it is my last lecture in head and neck. I cannot admit that I covered everything in the head and neck, but I tried to cover as much as I can. I think we previously, the last lecture, it was the orbit, and before that the skull base and the ear, and I think if you can go through the recorded lectures on the site, and if you have any queries or you want anything dedicatedly to be explained, you can email me or message me, and I during the MSK curriculum I can secure a gap for 5 to 10 minutes for any explanation or any points in the head and neck. Just the email, you can email me or send to the revise on the group, or you can send the messages to Becky or Marianne. My lecture today will be interactive, and I will be happy if you send me your impression on the message system. Okay, so my first lecture, this is the first case. What is your impression? I will check the message. Okay. You want me to raise my voice, or you want it is louder? Okay.
It's fine on my side.
Okay. Okay. No messages. Yeah. Okay. Okay. Very
There's
good.
a message.
Yeah. Okay. What else? I have in this case. It is very nice case. All the cases today are expected to be in the FR/CR exam. All of them very important cases. Okay. In this case, we have here hypodense right tonsillar cystic lesion in keeping with abscess. We have here filling defect in the internal jugular vein, partial thrombosis, which appear here also at that level. Here there is embolism, wedge-shaped or peripheral opacity. This is all these finding. Very good, Mahdi. Very good, Mahdi. These are in keeping with Lumiere syndrome. Okay. Thrombosis, infection. The problem started. Infection could be addict. The patient could be addict because it is right side. Right could be through the right side pathway. That is very difficult to in the normal person. Right side patient could be addict. The patient has infection in his mouth or mouth floor, thrombosis of the internal jugular vein, then septic thrombus of the lung. Okay. Okay. Next, Lumiere syndrome, classic triad, pharyngitis, neck vein thrombosis, cavitary pulmonary nodules. Other sites of metastatic infection may occur. Okay, making this diagnosis is a key to accurate antimicrobial therapy and anticoagulation. Okay. Next case, this is the other example for Lumiere syndrome in the there is this septic embolus, thrombus, and it is an abscess. معلش يا يحيى بس انا عندي محاضره حبيبي. Okay, this is thrombus, this is the abscess, and it is thrombus, and this is a septic embolism. Okay. Next case, newborn baby has a mass in the lower neck. A lot of problems because of this mass, a lot of debate and investigations beside some diagnostic procedures. Very good, very good, very good, very good. This is fibromatosis coli or pseudotumor coli. This patient, unfortunately, could be overcalled as sarcoma or like that. Unfortunately, if you are not aware of this problem and you can get a good history, a lot of problems for the family for the family of these patients will happen and the long pathway. Okay, so if you have this the knowledge is a power, and you can help the people with your knowledge. This simple knowledge, if you can know this, if you know this, you will save a lot of time. Don't underestimate this, because you will face this problem and you will find that it is missed or overcalled by many of the radiologists. Okay, fibromatosis coli, the ultrasound, which is the best imaging technique. CT in a newborn, no need for CT, but also sometimes it can be done. It shows diffuse enlarged muscle or focal mass within the muscle. This sternocleidomastoid muscle, which can be isoechoic, hyperechoic, or hypoechoic, varies with lesion age. Mass moves with the action of the muscle. When you ask the patient to move, to do some manipulation, it moves. It is because it is part of the muscle. It is like tear and the hematoma and the mass in the sternocleidomastoid. In the MRI, low signal fibromatosis, it is pseudofibromatosis or fibromatosis coli. Fibromatosis, low signal in all sequences. Enhancement of the lesions are variable, and sometimes when it is some early, it can be enhanced before, and this can be a reason for overcalling to be explained as malignancy. Okay, this is fibromatosis coli, here post contrast, pre contrast, and here it is in the CT. Okay, next case, multiple cervical lymph nodes, sinusitis. I wanted to see the messages. Yeah. Any answers? Just to try to accept. Don't be shy. Don't be shy, please. Just explain your ideas. Let me listen to you. Okay, multiple lymph nodes, multi-leveled lymph nodes. Okay, active but with the sinusitis, TB, not sinusitis. Wegener is a good explanation, but not with the lymph nodes. When you find sinusitis, septal perforation and the lung, I will call it Wegener. Okay, Cartagner, not Cartagner, fungal. Oh, it is histiocytosis. It is Rosai-Dorfman disease, multiple lymph nodes and sinusitis. This is subtype of the histiocytosis. Multiple lymph nodes, sinusitis. So this is multiple cervical lymph nodes. This is Rosai-Dorfman disease. Okay. The other things which can happen, it will not come in the exam, the other thing, but for your knowledge, when you find multiple subcutaneous nodules and the multiple cervical lymph nodes and also hypertrophied glands, is Kimura disease. Kimura disease. Okay. Rosai-Dorfman disease is massive bilateral cervical lymphadenopathy in the head and neck extranodal sites in 50%. Skin, it involves skin, sinonasal area, orbit, eyelids, bone, salivary glands, and the dura. Rare other extranodal sites, it's the OR, are the oral cavity, pharynx, trachea, bronchi, mediastinal lymph nodes. Okay, CT and the MRI is homogeneously enhancing large lymph nodes, enhancing extranodal infiltrates, and T2 loose signal of the nodal and or extranodal lesions. Okay. Here it is the examples. This is what's called, this is the extranodal. This is the extranodal. Okay. This is the extranodal. This is a node and this is the extranodal. Okay. Just to explain these points. Okay. So this Rosai-Dorfman, this can come in the exam. Yes, can come in the exam. Okay. It is present in some few books of the FRCR, but I think it will not be a problem. You have now the keywords, okay? Nodal and extranodal infiltration in the and paranasal sinus in the chest, Wagner, paranasal sinus and paranasal sinus and multiple cervical lymph nodes. This is Rosai Dorfman disease. Okay. Any questions regarding this case? Okay, let's move to the next one. Okay. Yeah, your impression? Great. What else? Yeah, I understood it, Navi. Yeah. Navi. Other options? Other differential? No, don't worry. It is, I think, young age, very clear that the bone and the appearance are young age. Yes. Yes. Adolescent. What is this? I'm sorry. What can you clarify? Infection? No, it is a nasopharyngeal angiofibroma. Okay, nasopharyngeal angiofibroma. It is based mainly on the sphenopalatine foramen. Sphenopalatine foramen. It is hyperdense in the CT, enhance and the multiple these signal voids because of the vessels. These are the signal voids, and the intense enhancement. This is typical for angiofibroma. Typical for angiofibroma. Okay, is considered as emergency because this patient is contraindication to do any nasoscope. You cannot go through his nose, and because you can injure this mess. Okay. Yeah, no worries. This, but the main this is just expansion. But mainly here, the lesion is here in this region mainly. Okay. Yeah. You have to make mapping and start with the embolization, and it has incredible response. Can anybody let me know what is the supply? From where the supply? There is a voice in my ear. I'm sorry. Anybody? Excuse me. Can you mute?
Can I answer?
No worries. Yeah.
It's supplied usually from the internal maxillary branch of the external carotid artery.
Okay. Thank you so much. Thank you. Okay. Next case. But just let me give some points on nasopharyngeal angiofibroma. This centered in the posterior nasal cavity, arising at the sphenopalatine foramen, extend into the nasopharynx, sphenoid sinus, pterygopalatine fossa, masticator space, orbit, and the skull base. Once you are in this region, who mentioned that there is extension. Once you are in this region, this is the pathway to the orbit through this pterygopalatine fossa and the masticator space. You can go everywhere in the skull. These foramens through the pathway of the foramen and the nerves. Okay, so don't be dumbfounded or surprised when you find something extending to the orbit from this region. This is very common because the pathways through the nerves are intact. Okay. I think I do believe that we have many differential, but at this age with these features, it is unaccepted in the exam to tell them any differential. In this age, can you say that it is cancer in this age? No. Okay. No, you cannot say this cancer in the at that age. Okay. Fungal sinusitis. I'm sorry. You mentioned fungal sinusitis. It is not sinusitis. And the main lesion, the fungal sinusitis starting from the sinus, and when it is invasive, it invades the bones. Okay, but mainly the main bulk of the lesion is within the sinus. The bone here, the angiofibroma, it can destruct, but very late. But it starts with bone remodeling. It remodeled the bone. Okay, you understand? Start even large size. It remodeled the bone first. Then, yeah, the structure could be a late presentation, but fungal sinusitis, the main bulk, when you want to say describe a lesion, and it's exactly describe the anatomical side, look at the main bulk of the lesion. Where is the main bulk of the lesion? Okay, and then say that this is coming from the sinus or coming from the posterior nasal fossa or like that. Okay, I hope this is clear. Thank you. It's okay. CT find heterogeneous, diffuse, avid enhancement, bone remodeling, first, late destruction, because of the avascular because with the pressure, this can interfere with the vascular supply, okay, of the bone. So destruction will happen later, but it will start with remodeling. Okay, posterior wall of maxillary sinus wound anteriorly, skull base invasion could happen. Yes, could happen. Okay, MR finding tubular signal voids on spin echo based sequences due to fast flow. The vessels appear as signal void. Okay, in the spin echo without contrast, if you the normal vessel, if you find the vessel hyper intense, raise a concern about thrombus, especially in the T2. T2, if you find hyper intensive vessel in the T2, there is a high possibility of being thrombosed. Okay, intense enhancement angiogram and the feeding artery internal maxillary branch with cheese branch of the external carotid artery. Excellent answer. Okay, next case, just ahead is some differential, but for me, I will, and I think in the exam these other differential are not accepted. Angiomatous polyp, it is very rare. Rhabdomyosarcoma, it is something not the presentation is different. The rhabdomyosarcoma, although it is the most common sarcoma at that age around 7 years, but is not the best, is not, I think it's not an appropriate differential diagnosis. Nasopharyngeal cancer, not at that age. Nasopharyngeal teratoma, the signal is different in the MRI. Lymphangioma, cystic, no contrast enhancement. Encephalocele, no contrast enhancement. So I do think this is just the masses in this region, okay, but the age is the age and the presentation is, if you just you know it, you cannot invite other appropriate differential. Okay, regarding this case, what's your impression? The polyp is bit late presentation. Okay, angiomatous polyp. It is neuroblastoma, very difficult, and the center is not here. Center around the olfactory nerve. Okay, it comes like hourglass lesion, part intracranial and part extracranial. Abscess will be low density in the CT, and then with rim enhancement. Okay, I speak about the abscess here. Okay, it will be fine. Yeah. Okay, what about this? Does it make sense? Does it make sense? Okay, great. Okay, so this sialadenitis secondary to obstruction by a stone. Don't underestimate these cases. These cases comes in the exam. Okay. Okay. The differential diagnosis for any enlarged salivary gland Sjogren syndrome, you have to search for bilaterality, and the other salivary glands, cyanosis, sarcoidosis, sure sarcoidosis, and other granulomatous disease, submandibular masses, neoplastic and the non-neoplastic, especially at that age. This patient comes with a history of long history of alcohol intake, okay, and low hygiene of the mouth. Infected branchial cleft cystic anomaly, but not typical, but it can also a weak differential diagnosis. Okay, next case. What's your impression? What else? Any answers? Okay. 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 It is chordoma. This chordoma, and I think the other differential is accepted also, but midline cervical chordoma in the children, chordoma are more common in the cervical region, here in the cervical region, and in the older age it is in the sacral region. Okay, this cervical chordoma, it is in the clival sacrococcygeal in the children, more common in the adults. It is sacrococcygeal more common. Osseous destruction, circumscribed, well circumscribed, scalloped or sclerotic bony margins, amorphous intratumoral calcifications, hyperintense, it is very high, sometimes very high in the T2, may extend into disc space involving 2 or more adjacent vertebrae, normal or decreased uptake in bone scan. So you cannot depend on the bone scan unless you suspect chondrosarcoma. Okay. Differential skull-base chondrosarcoma, more to one of the sides, calcifications. Okay. Skull-base meningioma, metastatic, including lymphoma and the Langerhans cell histocytosis. Actually, this is very odd and very difficult. Very difficult when it comes. It has variable presentation, and you will be very skeptical to call it, but it's still a differential. Okay. Plasmacytoma, not for me, not. It could be, but very difficult, very so far differential, literally. Brainstem glioma, no, brainstem glioma. The main bulk, the epicenter, the main bulk of the region should be from here, from the brainstem down, and this will be associated with hydrocephalus. Okay. Plasmacytoma, we speak about the myeloma, multiple myeloma, and this is a single lesion of multiple myeloma, but I actually it was a bit so far differential from my mind. Okay, I will not call this differential. Giant cell tumor, more posterior element, not the body. Okay, not the clivus, the posterior element of the vertebrae. Okay. Okay, next case. I will give you 1 point in the history. The patient has a history of HIV. Great. Okay, thank you. This is parotid lymphoepithelial cyst, which is characteristic of HIV. Okay. Parotid, these in the CT, enhanced CT or MR, multiple bilateral well circumscribed cystic and solid masses within enlarged parotid glands. The lymphoepithelial cyst wall may be nodular lymphoid follicles. Look for other contrast enhanced CT findings associated with HIV, reactive cervical adenopathy, and tonsillar hypertrophy. Okay, next case. No mercy in this case. Yeah, great. Why prevertebral? Who said why prevertebral? Prevertebral. This is a prevertebral. Just I'm clarifying. I want you to say everything in your mind, even wrong. We will correct it. Okay. But why prevertebral? There's no prevertebral. Here it is, the epiglottis. Here it is, the epiglottis. Okay. Epiglottitis. This is an emergency. Abscess. Okay. It is centered in the epiglottis. Something. It is not. This is the epiglottis. Okay. This is the epiglottitis. This is not an abscess. But this is epiglottitis, and it is emergency. This is very clear structure in the X-ray. Epiglottitis. Very clear structure. Okay. But I cannot say why abscess. Abscess in the epi will be on one of the sides, but not in the epiglottis itself. Okay. In the abscess, you have to check for other side. If you speak about abscess in the where exactly the abscess, in the mouth floor or in the prevertebral region, retropharyngeal abscess. But when you find this, call it epiglottitis. Don't call it an abscess. Okay.